What if the position has never actually been the problem? Pain during intimacy after 60 is not something you have to live with, and in most cases, it has almost nothing to do with the position you have used your whole life. By the end of this video, you will know exactly why the pain happens and the 4 specific positions that work with your body instead of against it. But first, stay with me for 2 minutes, because the reason intimacy hurts now is not what most women assume, and once you understand it, the 4 positions I am about to show you will make complete sense instead of feeling like random suggestions. If intimacy currently causes burning, tearing, or deep pressure pain, write "it hurts" in the comments. Or write "avoiding it" if the pain has caused you to stop trying altogether. There is no judgment here. This is one of the most common things women come to me about, and almost none of them know why it is happening. Let me tell you about a patient I will call Susan. She was 64, married for 31 years, and had quietly stopped being intimate with her husband over the previous 2 years. Not because she did not want to. Every attempt hurt, sometimes a sharp tearing sensation, sometimes a deep ache that lasted for days afterward. She told me she had started making excuses, going to bed earlier than her husband, anything to avoid the conversation about why. She assumed her body had simply changed shape in some permanent way that made the positions they had always used impossible now. What Susan did not know is that her body had changed, but not in the way she thought. And once I explained what had actually happened, 4 specific position adjustments solved almost the entire problem within a few attempts. I am Dr. William Harrison, a gynecologist specializing in women's intimate health after menopause. Here is the part nobody explains clearly. Pain during intimacy after 60 almost always comes from one of 2 specific anatomical changes, and which one is causing your pain determines exactly which positions will help and which ones will keep hurting no matter how careful you are. Subscribe to this channel if you want this kind of direct anatomical explanation, the kind most appointments rush past in 5 minutes. The first change is thinning of the vaginal walls. After menopause, the tissue lining the vaginal canal becomes thinner and less cushioned. Tissue that used to absorb pressure comfortably now transmits it more directly, which is why deep penetration that was once comfortable can suddenly feel sharp or tearing. This is the most common cause of pain, and it responds extremely well to depth control through positioning. Women experiencing this type typically describe the pain as sharp, located toward the back or sides of the vaginal opening, and most noticeable specifically with deeper movement rather than throughout the entire encounter. The second change is a shift in the angle and position of the cervix and the upper vaginal area. As pelvic support tissue loosens slightly with age, the angle that penetration naturally travels can change just enough that what used to align comfortably now creates direct pressure against a sensitive area, often experienced as a deep, aching pain rather than surface burning. This responds best to angle adjustment rather than depth control. Women experiencing this type typically describe the pain as a dull ache deeper inside, sometimes lasting hours or even into the next day, and occurring even with penetration that does not feel especially deep. Here is why this distinction matters so much, and it is the open loop I want you thinking about as I walk through the 4 positions. The same position can either solve your pain completely or make it worse, depending entirely on which of these 2 causes is actually behind it. This is why generic advice to just try a different position so often fails women. Nobody tells them there are 2 different problems requiring 2 different solutions. And using the wrong solution for your specific cause explains why some women try a new position and still hurt just as much as before. I will tell you which type each position addresses, so you can match it to what you are actually experiencing. Position 1 is side-lying with shallow penetration, and this addresses thinning vaginal tissue specifically. Lying on your side with your partner behind you, with your knees drawn up slightly toward your chest, naturally limits how deep penetration can go while keeping good contact and intimacy. The reduced depth means less pressure on the thinned tissue at the back of the vaginal canal, which is typically where the sharpest pain occurs. This position also allows your partner's hand to easily reach the front of your body for additional touch, keeping intimacy connected rather than feeling purely mechanical because of the depth limitation. The key adjustment that makes this position actually work, rather than just being a slight improvement, is communicating the word shallow explicitly beforehand. Without that specific instruction, the natural tendency during intimacy is for depth to increase as arousal builds, which defeats the entire purpose of this position. Say it plainly before you begin. Shallow only, and adjust together as you find what is comfortable. Many couples who try this position for the first time describe an adjustment period during the first attempt or two, simply because shallow penetration feels different from what either partner is used to. This is completely normal and tends to resolve quickly once both partners stop unconsciously comparing the sensation to what used to happen, rather than focusing on whether this particular attempt is comfortable. A small additional pillow between your knees can also help maintain the angle that keeps depth naturally limited throughout, rather than relying purely on conscious effort to hold position. Position 2 is the modified missionary position with a pillow, and this addresses the cervical angle issue specifically. Lying on your back, place a firm pillow or cushion under your hips, raising them slightly. This changes the angle of your pelvis, which in turn changes the angle that penetration travels relative to your cervix. For many women, even a small elevation, 2 to 3 inches, shifts the angle just enough to avoid direct pressure against the area causing the deep, aching pain. This position requires some experimentation with pillow height because the correct angle is different for every woman depending on her individual pelvic anatomy. Start with a smaller pillow and adjust upward only if needed. Most women find their adjustment within 2 or 3 attempts once they understand what they are adjusting for, rather than guessing randomly. One detail that makes a meaningful difference here is the firmness of whatever you use to elevate your hips. A soft pillow that compresses under weight will not maintain a consistent angle throughout, which means the very adjustment you are relying on can quietly disappear partway through. A firmer cushion, or even a small rolled towel inside a pillowcase, holds its shape and keeps the angle consistent. Some women also find that slightly bending their knees and letting their feet rest flat allows for small additional adjustments to the angle simply by shifting how far the knees are drawn up, giving a second layer of fine control beyond the pillow alone. Position 3 is seated, facing your partner, and this addresses both causes simultaneously, which makes it one of the most universally helpful positions for pain after 60. In this position, you are sitting on your partner's lap, facing them, with your feet on the ground or on the bed for support. Critically, you control the depth and angle entirely yourself through how you move, rather than your partner controlling the motion. This control is the entire point. If your pain comes from depth, you simply do not lower yourself as far. If your pain comes from angle, you can adjust your own position slightly forward or back until you find the angle that avoids the pressure point. Most women describe this as the position where they finally understood, through direct feedback from their own body in real time, exactly what was causing their pain in the first place. Information that then helps every other position work better too. Position 4 is rear entry with a significant forward lean, and this is specifically for women whose pain comes primarily from the angle issue rather than depth. Standing or kneeling, lean forward significantly, supporting yourself on a bed, a couch arm, or counter at the right height. This forward lean changes the angle of your pelvis in the opposite direction from the pillow-elevated position, which works better for some women depending on their specific anatomy. The reason I include this fourth position, despite it seeming similar to a position many women have already tried and found painful, is the degree of forward lean. Most women who try rear entry positions do not lean forward nearly enough, keeping their back relatively upright, which preserves the very angle causing their pain. A significant lean, bringing your chest much closer to horizontal than feels initially natural, is what actually creates the angle change needed. This is also why depth needs to be kept shallow and gradual in this position specifically, since the changed angle alone is doing the work, not depth. Susan tried positions 1 and 3 first, since she was not certain which type of pain she was experiencing. Position 3 gave her the clarity she needed within a single attempt. She immediately noticed that controlling her own depth eliminated almost all of her pain, telling her clearly that depth, not angle, had been her primary issue all along. She and her husband then used position 1 regularly going forward, with significantly reduced pain from their very next attempt. 6 weeks later, she told me something that stuck with me. She said the hardest part had never actually been the physical pain itself, difficult as it was. The hardest part had been the 2 years of feeling like she was failing at something she could not even properly explain, watching her marriage quietly lose a piece of itself without understanding why. Once she understood the actual cause, even before the positions fully solved things, she said the relief of simply knowing was almost as significant as the pain relief that followed. Lubrication matters enormously alongside all 4 of these positions, and I want to be direct about something most women get wrong here. A small amount of lubricant does not meaningfully help with the kind of pain we are discussing today. You need a generous amount, reapplied during the encounter if things feel dry again, using a water-based formula without glycerin or parabens, since those ingredients can cause irritation that compounds whatever pain you are already managing. Many women associate needing lubrication with something being wrong, when for women over 60, it is simply a normal and necessary part of comfortable intimacy, no different from any other adjustment your body needs as it changes. Pacing matters just as much as position. Rushing into deeper or faster movement before your body has had time to adjust, even within a position designed to help you, frequently recreates pain that the position itself would otherwise have prevented. Begin every attempt slowly regardless of which position you are using, and let your own body's response guide the pace from there rather than predetermining it beforehand. A few mistakes to avoid completely. Do not push through sharp pain hoping it will pass. Sharp pain almost never resolves mid-encounter, and continuing typically makes the next attempt harder rather than easier. Do not assume one failed position attempt means none of the 4 will work for you. Different positions address different causes, and the first one you try might simply be addressing the wrong cause for your specific anatomy. And do not skip the conversation with your partner about what you are adjusting and why. Partners who understand the actual anatomical reason behind a position change are far more able to help you find what works than partners simply told to try something different with no explanation. If pain persists despite trying all 4 positions with proper lubrication and pacing, or if you experience bleeding alongside the pain, this is worth a direct conversation with your gynecologist rather than continued self-adjustment. In some cases, more significant tissue thinning benefits from localized estrogen therapy alongside positional changes, and a doctor can determine whether that additional support would help your specific situation. For most women, though, identifying which of the 2 causes is behind their pain and matching it to the right position resolves the majority of the problem on its own, the same way it did for Susan. Here is your plan. Tonight, or whenever you next attempt intimacy, start with position 3 to gather information about whether your pain is primarily about depth or angle. Once you know which it is, move to position 1 if depth was the issue, or position 2 or 4 if angle was the issue. Use generous, glycerin-free lubrication throughout and communicate the specific adjustment you are making with your partner beforehand rather than during. Share this with a woman who has quietly stopped trying because of pain she assumed was permanent. Leave me your comment. It hurts or avoiding it. I am Dr. William Harrison. The pain you are experiencing has a specific anatomical explanation, and that explanation comes with a specific solution. You do not have to accept this as simply how things are now.